State Department grant to to create an infection control prevention network, which means we're going to have an infectious disease consult center. Problems related to prevention can be addressed with that. And one of the goals is to participate and collaborate with ECHO to disseminate more information. We can move to the next slide. So Project Firstline, which is under which we all come. This is a sub grant that I was talking about. So Project Firstline is a national collaborative led by the U.S. Center for Disease and Control to provide infection control training and education to frontline healthcare workers and public health personnel. AAP has partnered with Project Firstline, and AAP, the West Virginia AAP has gotten a sub grant for this. The contents of this program do not necessarily represent the policies of CDC or HHS and should not be considered an endorsement by the federal government. We can go to the next slide. A little bit more about Project Firstline. It's an infection prevention control training collaborative. It aims to provide foundational and practical knowledge to all frontline healthcare workers. There are multiple training opportunities, as well as to build more expertise. And goal 201 is what we are working on by creating that infection prevention network, and then telementoring in communities of practice. We can go to the next slide. This is our beautiful WVU faculty team, and there are more people in this. So Dr. Moffat, Dr. Weiss, me, Dr. Reese, and Dr. Costello will all be doing some educational sessions, as well as there'll be more faculty as we go along to discuss all the different sessions or didactics that are in this. We can move on. Also, Marshall, for that big DHHR grant, Marshall is part of that grant, so there might be some faculty coming in from Marshall too. When I first heard the term Project ECHO, I did not know what ECHO was. So this slide helped me learn that and understand what Project ECHO was. So you guys have been here longer than me, so I would skip, but all teach, all learn, encourages knowledge exchange, utilizes technology, and promotes case-based teaching and learning. We can go to the next slide. So what are the goals of AB infection prevention and control, risk recognition and communication with ECHO, to help increase clinician knowledge, skills, and self-efficacy around risk recognition and communication of infection prevention and control relating to COVID-19. But these are a little, like, we've been dealing with this for 1 year. So with COVID, SARS-CoV-2, we have a good understanding of, but the same principles will apply to any infection. So we want to be prepared and have these skills in place so we can be ready to tackle the next one. Also to provide a forum for mentorship and support during COVID-19 pandemic. Dr. Costello, is there something more? Is there something I'm missing from this?
No, I think Dr. Gupta, you covered that well. I think that from the pandemic and we're seeing a lot of funding even more now, to kind of really recommit to different coordinated efforts. And so in the West Virginia chapter of the AAP, we, along with other chapters, were able to get some information or get some funding to help support. And then Dr. Gupta is doing a great job in collaboration based upon what she's going to keep talking about for this statewide network in a partnership with the Department of Health and Human Resources. So yeah, we will be, we appreciate Dr. Gupta. We, at least in the pediatric space, plan to do more of these lectures. Dr. Gupta is going to be speaking at our annual meeting that's coming up, and appreciate this platform that we can continue to have this discussion moving forward, really about infection prevention and control. But thanks, Dr. Gupta.
Thank you. All right, we can go to the next slide. Okay, so we'll be going through the basics of infection transmission of all infections, as well as COVID-19. We can go to the next slide. I don't have any disclosures with any manufacturers of commercial products, or I'm not gonna discuss any investigative or unapproved medication or device. We can go to the next slide. Objectives for this presentation: understand routes of general infection transmission, understand how SARS-CoV-2 is transmitted, understand the rationale for infection control practices for SARS-CoV-2, and discuss some SARS-CoV-2 transmission scenarios. And at that time, I would like to open it up for discussion to hear like all the challenges that everyone has faced in their practice, especially early on during, I look back at April, May, June, when we were having random cases, and especially if you had a healthcare worker who was exposed or came back from spring break or summer travels, and how the situations that you guys dealt with and how everyone handled it. So it would be really nice to open up for the discussion. I have a case at the end, but I would love to hear from what if anybody has encountered this during practice, and I would be really surprised if nobody has had this. We can go to the next slide. So what is an infection source? Looking at the project Firstline, if you go to the website, the main emphasis is like to try and figure out what the basic and why we do things, to understand why we are doing something. So they have broken it down to really short videos that you can watch, and they really just dumb it down to not, you don't even have to even think about like, oh, what is SARS-CoV-2 and what is the difference between the SARS-CoV-2 and COVID-19? Like 1 year down, we know. And I apologize, these slides might seem repetitive, but there are certain points that they really want to emphasize. So I will cover those. So what is an infection source? Infection source is a source in any place where infectious agents or pathogens live. It can be found in various places in the healthcare settings. Primary reservoirs for most infections are people, patients, healthcare workers, visitors. Devices are big, indwelling medical devices like catheters and IV lines. Environmental surfaces also play a huge role, like dry surfaces in patient care areas, bed rails, medical equipment, countertops, tables. Wet surfaces, moist environments, and biofilms, like the cooling towers, which are associated with Legionella outbreaks, faucets, sinks, and equipment such as ventilators. Dust or decaying debris, construction, if there's ongoing construction around the area, if the ventilation system is not secure, or if there is an issue, there's a breakdown in the ventilation system, you can get infection from through the spores traveling through the dust, or wet materials from water leaks. We can go to the next slide. What is infection transmission is how it will move from the source to a susceptible person. So pathogen depend on people, the environment, or medical equipment to move into healthcare settings. And what are the major modes? Contact, sprays and splashes, inhalation, and sharp injuries. What is really different is they have moved away from that droplet and airborne, how we used to read about. They have completely eliminated those definitions like droplet and airborne. So we'll go over those. So sprays and splashes were the old droplet, and inhalation is the new airborne transmission. All right, we can go to the next slide. So contact pathogens, best examples are MRSA, VRE. Healthcare providers their hands can become contaminated by touching pathogens on various medical equipments or high touch surface areas. If hand hygiene is not performed after touching all the surfaces, we have the ability to transmit it to a susceptible host, or we can carry it around to another patient's room. We can go to the next slide. Sprays and splashes. I found this really good cartoon and I love it. Like a green booger spraying all over. This is like the best how kids behave. Sprays and splashes occur with any fluid, especially when infected person coughs or sneezes, creating droplets which carry pathogens through short distances. So you can see how the puppy got sneezed on with that green booger. these pathogens can land on susceptible person's eyes, nose, or mouth and can cause infection. Best example, pertussis, meningitis, or all kind of our old droplet infections. Close range inhalation occurs when a droplet containing pathogen is small enough to breathe in, but not durable over long distance. So this can still happen if you breathe it in, but usually these particles are so big that our immune system is able to tackle them. We can go to the next slide. Inhalation occurs when pathogens are, so this is our old airborne transmission, and where pathogens are aerosolized. So they're really small particles and they travel through the air currents over greater distances. So this would be a cartoon depicting a person coughing, but also generating some aerosol transmission, which is traveling over a longer space. Airborne transmission can occur when infected people cough, talk, or sneeze, therefore making these particles really small. Or in SARS-CoV-2, we learned screaming, shouting, singing were one of those in which you could generate a smaller viral particle and you could transmit it at a longer distance. TB, measles were the classic examples for airborne. The other pathogens that we think about in aerosolized that can be transmitted by aerosolization are non-tuberculous mycobacterium or aspergillus. So with construction or dust from construction zone, it can drum that up, transmit those spores into the ventilation system and travel longer distances. We can go to the next slide. Sharp injuries, these are old blood-borne transmission that can lead. Common examples are HIV, Hep B, Hep C. Pathogens enter a person through a skin puncture by a used needle or a sharp instrument. We can go to the next slide. Oh, I put a cartoon in here. Anyone? No one? Okay. I would pause here for any questions. I have not been looking at the chat. Mitra, do you see any questions?
I don't believe any questions have come in at this moment. No.
Okay. All right, we'll just keep going. So we have more time for discussion on the cases, right? COVID-19, what we know, thinking about the epidemiology of SARS-CoV-2, most of the infections are spread through close interactions with infectious individuals, being within about 6 feet or in shared, poorly ventilated space with an infected individual for a longer period of time can increase the risk of transmission. So there used to be the 15-minute rule, like if you were not in the room for 15 minutes, but if you were over like an hour but you were 5 minutes and 5 minutes and 5 minutes and 5 minutes, that all adds up. So that's what they mean by extended period, also increases the risk. We can go to the next slide. So it spreads very easily. We have learned that. And I apologize if all of this is like old information, but I think there's a lot to be learned from the transmission and all the new information that we have seen. So it spreads from person to person, including people who are not sick. Like flu, it spreads mainly between people when they're close together through respiratory droplets when the infected person coughs, sneezes, or talks. There is limited evidence of transmission through chemical absorption, that is through the skin. But mucosal surfaces are your big area where you can acquire it. In general, the closer a person interacts with the other and the longer the interaction is, that it increases your risk to getting SARS-CoV-2. So these are the points that they really wanted us to emphasize. We can go to the next slide. Again, this is the same thing. Closer a person interacts, longer the interaction is the higher risk. Being in an enclosed space without good ventilations, especially in overcrowded situations, also breathing hard, shouting, or singing can increase the risk of infection. So gyms were a place where infections really spread. SARS-CoV-2 can be aerosolized through aerosol generating procedures like intubation, or if you have somebody on a high flow nasal cannula with a really high flow. So that should be avoided if possible. This was the initial guidance that came through CDC too. We can go to the next slide. Oh, and I found another cartoon. There were a lot of cartoons I could find on SARS-CoV-2. We can move to the next slide. So how can we minimize the risk? Distancing is a big one, and then also optimizing your indoor air quality. So ensure that care processes do not require people to be close together except when clinically necessary. So considering the layout of your waiting room to see if there is people are not standing in a close by queue, putting stickers, which is really well laid out, especially in the grocery stores, to figure out like where you want to have people situated, and make sure your HVAC systems have been inspected, optimized, and then review standards for air exchanges in clinical spaces. So if you go to this website, they have for clinical spaces like what your air exchanges should be. When I was reviewing all of this information for education purposes for families, like what guidance do you do if you have a family member who is positive? CDC's guidance was turn your fan on your ventilation system to on, not leave it on auto, turn it on or keep it running consistently so that you're having more air exchanges. The other thing that is put here too is consider auxiliary filtration if appropriate. So that's what we did in the hospital. We created a bunch of, we put out a bunch of HEPA filters. We were able to circulate and increase more filtration. We can go to the next slide. Oh, again, avoiding aerosol generating procedures, because even though these are aerosols, if you're generating them really close to the patient, all the people in a close proximity are going to get a really high burden of the viral load. So you want to decrease that either by putting them in an airborne isolation room when you're doing these procedures, and also by just having essential staff present. So people who are going to help with the intubation. Yeah, we can go to the next slide. Various infection control methods. These are critical tools to protect people from infectious diseases, including SARS-CoV-2. Preventing exposures is very important, especially when early on, when we did not have vaccine-specific treatments. I mean, treatments are still really, it was really surprising to see how quickly we were able to, and how rapidly the treatment modalities changed. And then these principles apply to all infections. Each component builds on the next and should be used together all the time. So source control, visitor exclusion, screening and triage practices, environmental and hand hygiene, and PPE. We'll go over each of these in the next few slides. We can go to the next slide. So source control should be practiced by everyone in the healthcare facility, wearing a mask to cover your nose and mouth at any time when you're closer to people. And think about masks when you're not in patient care areas. I mean, we have been doing this for almost a year, and it has shown improvement. Think about the break rooms. How are you spacing people out if they are sharing a break room? Having a plan in place so that everyone's not getting a break at the same time. So it's a crowded break room and everybody's warming up their food and eating together, which just increases your chances. Cloth masks should be worn by patients and visitors. Healthcare workers should wear surgical masks while at work and switch to N95s when caring for known or suspected COVID-19 patients. This guidance is old. We know that there is a different tier in the hospital too. If they are not having an aerosol generating procedure, then you can do a regular face mask, a surgical mask, and a contact isolation. But if there is an aerosol generating procedure, then you do respirators. We can go to the next slide. Triage and screening. And this I really want to emphasize, especially with all that's going on in West Africa, again, with Ebola and everything. Make sure we are screening our patients at the time of when we're making the appointments, instructing patients before seeking care if they can choose telehealth options, letting them know about telehealth options, as well as what they should expect on arrival for in-person care, like how many visitors can be in the room. Everyone needs to wear a mask. And if they have traveled, they should let us know. Requirements to report symptoms and exposures and wear a mask for a source control mask at all times, and then whether others are allowed to accompany them. This is always tricky on the PED side, and I would love to hear from everyone in the clinics outside to see what the experience has been with limiting the visitors. We have been getting especially in the hospital where we had limited visitors, we got into a lot of trouble. Also, think about supplies for respiratory hygiene and cough etiquette. I mean, early on, we all remember like the gloves were going missing, the masks were going missing because there was so much shortage. But having all those things visible so people can use them, hand sanitizers, tissues, no touch disposal receptacles, as also posters, visual signs to reinforce all of these messages are really important. We can go to the next slide. Limit and monitor points of entry to the facility. So having certain employee access points. So our hospital still has badge access to certain points, and patients and visitors only come through the main entrance or through the ER. Prevent crowding of patients in shared areas, limit the number of individuals in waiting areas, and then have patients with wait in their cars. We have all done this throughout this past year. Screen patients, visitors, and staff on arrival for symptoms consistent with COVID-19 or exposure to other SARS-CoV-2 infection, and ensure they are practicing source control. So reinforcing, please put your mask on, keep your mask on at all times, and things like that. We can go to the next slide. Oh, I found this one too. This would be every teenager, right? I am very good at finding jokes. Our infection control meetings have lots of cartoons in between. Mitra, let's pause here and to see if how things have been going or if there are any questions.
That sounds good. Thank you, Dr. Gupta. And I just have to say, I love all of your cartoons and graphics you included. I'm a big fan. But sure, anyone with questions or comments that they wanted to add, feel free to chat them in at any point, or just feel free to unmute as well and ask directly.
If not, we can keep going forward to get to the cases. Thinking about the PPE, I mean, I never thought about working in a small clinic, like how do you manage your PPE? Like how is there a process in place? How well PPE works depends on you. No matter how busy you are, you should take time to use the right equipment the right way at the right time. Early on during the pandemic, everyone said there is no emergency in a pandemic. So make sure you have your PPE on, make sure you're protected. And it's also protection for yourself and also for the patients. So it goes both ways. PPE care, we all know this, mask or respirator, eye protection, especially we figured out early on, like block splashes that land in the eyes do help with those big droplets that come into your eye. Gown and gloves. Hand hygiene has to be done after you remove your gloves, especially if you're really in high touch areas. All right, we can go to the next slide. So thinking about environmental hygiene, what early on, everyone, we all thought about this, like what things will work to help inactivate this virus. It's a lipid virus, has a fat-based external layer, so it is disrupted by detergents, alcohols, and the common disinfectants. So nothing special that needs to be done, just bleach or you know, if as long as you are able to kill the outer layer, you should be able to get through you should be able to inactivate the virus. Routine practices for hand hygiene, all of the common things that we are always working on in infection prevention, hand hygiene, environmental cleaning are effective against SARS-CoV-2 for maintaining environmental hygiene. We can go to the next slide. Think about your hand hygiene. WHO has these 5 moments for hand hygiene at the point of care. We all struggle with hand hygiene, especially during infection control meetings. When we look at the numbers, we're like, whoa, hand hygiene needs to be more rigorous. It should just be an automatic like brainstem reflex that before you go touch the patient, you clean your hands. So a lot of work still needs to be done, but simple. Washing your hands with soap and water or alcohol-based hand sanitizers are simple ways to preventing transmission or from you delivering the infection into your eyes, nose, or mouth, the way which every respiratory virus works. Soap and water, alcohol-based hand sanitizers. We can go to the next slide. A little bit about asymptomatic and pre-symptomatic spread. And this is something that SARS-CoV-2 has taught us, is that before a person became symptomatic, there was a 3-day window where they could potentially spread the infection. And this was the trickiest part. And that's why quarantining people exposed to SARS-CoV-2 was so important. Also, there are a lot of people who are asymptomatic, but they are still shedding SARS-CoV-2. So respiratory secretions, we've covered that, but I wanted to highlight this review article that was published, and that has been the backbone of our infection control recommendations in the hospital, where we have taken people out of isolation really early on, because we found that you could not culture virus almost after day 10 of illness. So this has been really helpful in conserving PPE, also improving patient care, because we know when patients are in isolation, it limits the amount of checks that we do on patients and things like that. So yeah, this was really helpful. All right, we can go to the next slide. So we're coming to the scenarios, and I saw a question pop up. What are your feelings on non-droplet aerosol spread, and how likely this is a mode of spread? So, I mean, I think we're still learning a lot, but thinking about the classical examples of measles and tuberculosis and chickenpox, like, it is not that much of airborne. Like, there are certain things that make it really airborne. So there is definitely a proportion of airborne transmission, but we never address this, or I know for sure I did not think about this. Like, did we think about airborne transmission for other respiratory viruses? So there is definitely a component of airborne spread, but it's not as much. I think about, I'm just making this number up, 85% would be droplet, and then some part of it is, oh my gosh, that leaves 15%. I would think like 95% is droplet, and the rest of that would be airborne transmission. Like, thinking about all the people who traveled on a flight, but they did not, the whole flight did not get it. Cruise ships were different. Like, you are in constant contact with other people, but if you're sitting in a spot and you have all this virus circulating, like, that is a different story. So that's how I feel. Dr. Moffitt, Dr. Costello, or Dr. Reese, anybody who wants to tackle this tough one?
So I think it's interesting that those of us who were around during that H1N1 year, which was a while ago now, if you remember, it came up about influenza being airborne, and we put in all those fans and those units in the rooms. We had specific rooms, and we did airborne for a while. So I think it could potentially be the same with influenza. If you're doing an aerosolizing procedure with someone who is extremely ill and has a high virus burden, then in that scenario, yes, that virus might be airborne, just like SARS-CoV-2 might be. But we have come to learn, or we've accepted, that influenza really isn't in most times. So maybe this virus has more of a potential to be airborne, a little more than some of the others. But I think of that as an example. There's even people who have argued that Staph aureus and these rafts of staph that could be in the room and whatever might be airborne. But we don't put Staph aureus in isolation. So I think there are scenarios, and but I don't think that it's very common.
Before we go into the scenarios, I would want to pause to see if people had any questions about the presentation. We're almost towards the end of my presentation. We'll just do these scenarios that were made.
So far, I think the only question that came in was the one you just answered.
Okay. All right. So, and probably everyone went through this when we did not know. So a nurse at your clinic has been exposed to a COVID-19 positive person 2 days ago. This morning, she has come in with nasal congestion. She feels unwell. She took some Dayquil and has been working until noon. She cannot taste or smell, but has allergies this time of the year. So she was like, this is allergy. Stop freaking out about me. And she's been hacking and coughing, and she is just miserable. She has been checked. And let's just go over, like, what are your thoughts about, say this was early, like April, when last April, when we did not know or traced any of the people or did not even have the testing ability. And we were we masking in April, May, June? I cannot even remember. So yeah. Any takers? No?
I always like to emphasize too to all the participants that this is a safe space, and feel free to chime in with your thoughts and comments, and absolutely zero judgment. So I just wanted to throw that out there to hopefully make everyone feel more comfortable in any way. But thank you, Dr. Gupta.
Guess we have no takers for this complicated question. Okay, so I mean, it will really depend on things like, was this nurse masking? Was she really adherent to masking? The high risk people would be in that pod. Like in our clinic, we have certain workstations where the nurses are together, and they often share. They often have drinks, not drinks, like coffee. They will have some coffee. They will keep sipping coffee. So that would be a high risk scenario. Like if both of them had their mask off during, if they were having a sip of water or having coffee, and they would be really close, because it's really hard to to distance them 6 feet. So those people, and then also if she took a break, did a lunch break and was eating lunch, those people, that's how you would start off these investigations. And I mean, 1 year through, we have, and I have not done, but the nurse managers have done an amazing job of doing these investigations whenever they have had these break room outbreaks, to figure out who was at high risk, who needs to be quarantined, who needs to get a test done. So about the other staff, I would think you would think about it, mask, not mask, who all were masked. And I think that at this point of time, everyone should be really truthful about if they were wearing a mask or not, or if they pulled the mask down or not. What do you do about the patients? That is really tricky. Like, what do you do about them? So again, if this was sometime early on when we were not masking in the healthcare facility, and Dr. Moffat can maybe add more to this, I would, if they were exposed to someone, and then I would I would call the families and let the families know that you were exposed. We would recommend, I recommend quarantining for, earlier on it was 14 days. You can shorten it depending on the different jurisdictions, but really, like, I would be really upfront and let the families know.
And Dr. Gupta, I'm sorry to interject here, but I did get a private chat from a participant saying if this were back in, April 2020, we would have asked about travel. And they were saying they think travel history to high risk areas or known exposures were the indications for testing when it was so limited initially.
Right, right. And we know this is from our clinic where one of the nurses had traveled to Florida, and the testing was so limited that she never got tested. And we were always like, you definitely had it, because she was sick, her husband was sick. But that was one of the scenarios where we had to, and that was again April, May, when we were still learning so much more. And I feel like now we have a better plan in place, but all of these principles will still apply to any other infection. I hope Ebola is not gonna be what we have dealt with for the past year, but any kind of respiratory transmission would be something similar. All right, we can go to the next slide, which is funner, because
So Shipra,
yeah.
So you have a good little teaser on that last slide about the smell and taste. So I don't know the percentage, but I think that people who lose their smell and taste from allergies or chronic sinus disease, I think that's a more like an older person chronic thing. And someone can correct me if I'm wrong, but I don't think that's something that kind of comes and goes with your just one little illness. I think it's really more of a chronic thing. So there also are, I think it's associated with dementia, losing the taste and smell. So I think you could discriminate that pretty easily. That's a more of a chronic thing, but I've had two people who I know very well who have told me in great detail that over an hour to 2 hours, they saw their taste and smell, or they felt it, they go away. And it was this, I mean, they knew it was there, and then they're like, uh-oh, and then they realize, and by 2 hours, it's gone. That's COVID-19.
Okay. So the reason why the nurse left was because the nurse got a call from a child's daycare. This sounds like my life every single day during COVID, was that the child had a fever. So she brings him to the clinic, and we all don't know about her loss of taste and smell, because I would not know what is going on the nursing side. So I swabbed her throat, and I was not wearing a mask, and I did not have goggles on. And then you also send a COVID-19 just because it's the season, and you find a positive test. And that's a really rapid turnaround. Like, you know about this in a day. So what do you do about the staff who saw the patient? And then what do you do about the disinfection of the room? So again, if I was not wearing a mask and goggles, I'm out, because I've been exposed to, while swabbing the throat, I have probably been splashed, play. So I would, for the person who's performing the throat swab would be out in quarantine for 14 days. In terms of like the staff, again, it will really depend on were they wearing PPE, were they wearing their mask. And we've had children, we've had pediatricians call us and are like, this family traveled, but they said they're just coming for a well child check. Then the child had a fever. And we've been like, okay, but were you wearing a mask? Yes. And then we all feel happy and we're comforted. So if you're wearing PPE, yes, then there's no quarantine. You just self-monitor for symptoms. Disinfection of the room, general, whatever hospital approved disinfecting agents you use those to clean that room. You don't need to burn that room down. Maybe for Ebola, we should burn that room down, but not for this one. The other, what's the other thing I was gonna say? It'll come back to me sometime. So again, about the staff who, so there was a serology study done on the internal medicine side where they did a lot of healthcare worker serology, and we found like if you were using PPE, the transmission in the hospital, transmission from patients to healthcare workers was really low. But the scenarios that we saw a lot, and probably everyone here did too, during the winter months when everyone was doing social gatherings and being more exposed, and then having sharing lunch together or in a break room, that is always that's what led to the little clusters that we saw in the hospital employees, but it was not a whole lot of hospital patient to healthcare worker transmission. All right, I will pause here and see if there are any questions. Nothing?
It's a quiet group today.
I know. All right, we can go to the next slide and then we can wrap it up. So the basic take-home messages: pathogens depend on people, the environment, or medical equipment to move in the healthcare settings. Common ways of transmission are contact, high for MRSA, VRE, sprays and splashes, inhalation, sharp injuries. Transmission of COVID-19 can be prevented through standard infection control protocols, which we will cover more in the upcoming sessions. I think I combined these two together, so it's already covered. And then the next slide has a summary of all the other, what the next sessions are going to focus on: scenarios around PPE, triage, applying current IPC guidance, communicating risk, and more. More of like, we just want to have that discussion so we are prepared, also to think about what systems we have in place in our clinical settings to be able to address this and not feeling overwhelmed. If we keep talking about it over and over again, it's just going to become just like how masks have become part of our life in the past year. I think and from what all the literature review, all the different opinion pieces that you're going to read, COVID-19, SARS-CoV-2 is not going anywhere. It's just going to become one of the seasonal viruses along with flu and RSV, which have been beautiful. Like they seem like they've been eradicated at this point of time by SARS-CoV-2. So masking does help. So just having these constant discussions is what our group wants to achieve through doing these sessions, and hearing from other people, general practitioners, to figure out like how we can provide more help and guidance. Okay, that's all from me.
Thank you so much, Dr. Gupta. And as I mentioned before, we always love having you on and truly appreciate your time giving these didactics. And absolutely, if any of you have any feedback on what you'd like to hear for a future COVID Echo topic, just shoot us an email and we'll make sure to pass that along to everyone as well. Were there any comments, questions, thoughts that anyone wanted to share? Dr. Costello, Dr. Moffitt, Dr. Reese? I think it's the weather today. It's April 1st, but it's snowing. So I think it's just the weather, you guys. And thank you, Elizabeth, also for chatting that in. We do have that survey from the AAP. If you all could take a moment to fill that out sometime after today's session as well, that would be absolutely wonderful. But I don't want to hold you all longer than we have to, but if there are any questions after the fact that any of you think of, as always, shoot us an email, let us know. We'll make sure to have it addressed. So I guess I can go ahead and pull up the poll, and looks like it is inactive right now. Elizabeth, I'm not sure if you have it on your end as well. If you hit that poll button, sometimes it goes inactive.
Did it work?
Is it up there? Yes.
Good, okay.
Thanks, Elizabeth. And everyone,
Perfect.
Awesome.
Thank you. Thank you so
Thank you,
much.
Anytime you guys finish this poll, just feel free to log off as well. And again, thank you so much, Dr. Gupta, for your time, and we'll see you all next time.
Thank you, everyone. Mitra, do I need to hit download?
No, you don't have to hit download or anything. If you just hit the X on the poll, it'll save it in the back end.
All right, perfect. Just making sure, because I was like, oh my gosh, I didn't do that last time.
No, you're perfect. Thank you so much for launching that.
Of course. All right, I'll talk to you in a little bit.
All right. Thanks, guys. Bye.